Today, we'll be hearing about exciting news in lung cancer, eribulin in metastatic breast cancer, and more evidence of a signal for cardiac problems with androgen deprivation therapy use. Later, in our feature story on death and dying, we'll talk about the resurgence in the controversy surrounding physician-assisted aid in dying for cancer patients. All that and more starts right now on UncLive News Network. Hello and welcome. I'm Laura Jones.
And I'm Justin Gallagher.
There's positive news for women with triple-negative breast cancer. Treatment with eribulin improved overall survival in patients with metastatic breast cancer following progression on a taxane and anthracycline. These results from a pooled analysis of two large, open-labeled, Phase 3 trials, Study 301 and the Embrace trial, were presented by Dr. Chris Twelves at a conference in Liverpool. In the subgroup of triple-negative breast cancer patients, median overall survival was significantly improved with eribulin 12.9 months compared with 8.2 months with physician's choice of chemotherapy or capecitabine. For patients with HER2-negative disease, overall survival was 15.2 months versus 12.3 months with chemotherapy. There was no benefit for eribulin in HER2-positive subgroup. Eribulin is already FDA approved for metastatic breast cancer that has progressed after at least 2 regimens, including a taxane and anthracycline. In other lung cancer news, first-line therapy afatinib improved overall survival by approximately 1 year in patients with advanced non-small cell tumors that harbor EGFR exon 19 deletions when compared with chemotherapy. There is no benefit for eribulin in the HER2-positive subgroup. Eribulin is already FDA approved for metastatic breast cancer that has progressed after at least 2 regimens, including a taxane and anthracycline. In other lung cancer news, first-line therapy with afatinib improved overall survival by approximately 1 year in patients with advanced non-small cell tumors that harbor EGFR exon 19 deletions when compared with chemotherapy. This is according to results from the Lung 3 and the Lung 6 Phase 3 randomized trials. The FDA approved afatinib last July for patients with exon 19 and exon 21 deletions. However, an intriguing finding from the studies was the lack of benefit in patients with exon 21 mutations treated with afatinib. Overall survival was similar for both study arms. Dr. Lisa Sequist, who presented the results at the Chicago Multidisciplinary Symposium in Thoracic Oncology, said that based on these results, tumors with exon 21 and exon 19 deletions need to be looked at as separate entities.
Results of a retrospective study of men with prostate cancer suggest that androgen deprivation therapy may be linked with a more than 3-fold increased risk of dying from cardiac-related causes in men who have heart failure or in those who have had prior heart attacks. Of 5,077 men in the study, 30% were receiving ADT. In the subgroup of men with cardiac disease, heart-related deaths occurred in 7% of men receiving androgen deprivation therapy, compared with only 2% of men not receiving ADT. Paul Nguyen of Dana-Farber noted, these results need to be carefully weighed against those of larger controlled trials that have demonstrated the benefits of ADT.
In news from the American Thyroid Association, several sessions at the ATA annual meeting highlighted next-generation sequencing for detecting cancer in indeterminate thyroid nodules. In one study, the ThyroSeq V2 next-generation sequencing assay was highly accurate in diagnosing follicular cancers with a sensitivity of 90% and a specificity of 93%. At this point, the ThyroSeq V2 test is the furthest along in development and has a reasonable amount of data supporting its use. However, another next-generation sequencing assay was shown to have a sensitivity of 89%. Other microRNA and gene expression-based tests presented at the meeting had accuracies in the 85% range.
A question often asked of oncologists by patients is, what can you do to help me live longer? Much less often, oncologists are asked, what can you do to help me die sooner? How many oncologists today would feel prepared to have this discussion with a patient? But this is a very question that is the focus of the controversial Death with Dignity Act, which has now been passed in 5 states, Oregon, Vermont, Washington, Montana, and New Mexico. Recently, the hot debate over the Death with Dignity Act was reignited when Brittany Maynard, a 29-year-old diagnosed in 2014 with rapidly progressing glioblastoma, launched a public campaign to raise awareness about her choice to die on her own terms, a choice she feels every patient with a terminal illness should have the right to make.
Advocates say that a patient should be able to choose whether they will endure the slow and often unbearable suffering associated with the terminal disease or its treatment. Glioblastoma is one that can end horrifically for the patients, and some patients want the autonomy to die at the time and under the circumstances of their own choosing and with the help of their physicians. Opponents say that the Death with Dignity Act sets a precedent that could easily be abused, citing the potential for influence by family members of a patient who is mentally or physically debilitated, particularly when considering the reduced cost and burden of aid in dying versus end-of-life care.
Brittany Maynard and her husband moved to Oregon, where she chose to die November 1st, 2014, in her home and surrounded by loved ones. Since the law was passed in 1997, 1,173 Oregon residents have had lethal prescriptions written for them, and 752 patients, almost 80% of which had cancer, have taken the medications, which are typically an oral barbiturate. A question is whether most oncologists would be prepared if asked by a patient for aid in death. According to Dr. Nicholas Gideons, assistant professor of family medicine at the Oregon Health and Science University, the states that were early adopters of Death with Dignity really forced a better conversation with patients about end-of-life, palliative care, and hospice care in general. He says that a patient's pursuit in aid of dying is not devaluing in any way the work of really good palliative care. It enhances it.
We thank you so much for watching this edition of OncLive News Network. I'm Laura Jones.
And I'm Justin Gallagher.
We'll see you next time.